Hello, my name is Jeff Reist, and I'm a clinical assistant professor at the University of Iowa College of Pharmacy. In addition to teaching pharmacy students, I have clinical responsibilities in the Geriatric Assessment Clinic at the University of Iowa Hospitals and Clinics, where I work with a team of nurse practitioners and a physician in an innovative home care practice. I am going to talk about the monitoring of antipsychotic medications used to treat the behavioral symptoms of dementia. As you learned in this series, these medications have limited efficacy and some pretty severe toxicity. As a result, we need to carefully monitor for effectiveness so we can stop the medication if it's not working, and for toxicity so we can continually balance the often limited efficacy with the known risk of therapy. The saga of Mrs. Annabelle Klein continues. She has recently been started on haloperidol for the management of psychotic symptoms and the potential danger that her behavior represents to herself and others. In this section, we will discuss proper management and monitoring of patients receiving antipsychotics for behavioral problems of dementia. As mentioned in the introduction to this section, our approach to a patient recently started on an antipsychotic medication must include monitoring for effectiveness and adverse effects. In the section on antipsychotic selection, we emphasize the importance of clearly documenting those symptoms and behaviors which may justify the cautious use of antipsychotic drugs in patients with dementia. These behaviors represent our treatment targets and must continually be monitored to determine whether or not the drug is helping to reduce or eliminate these target behaviors. Always keep in mind that the target behaviors a patient with dementia may experience will change over time with or without drug treatment. When an antipsychotic is initiated, it is unreasonable to expect an immediate reduction in target behaviors. If an immediate effect is seen, the adverse effect of sedation may be responsible. This should not be confused with effectiveness. Always keep in mind that if sedation is all that is accomplished by the addition of an antipsychotic, we can achieve sedation through the use of safer medications. The use of the antipsychotic should then be questioned. Remember, for the true effectiveness of an antipsychotic to be evaluated, we must be patient and continually monitor the identified target behaviors. Don't be in a hurry to increase the dose of an agent, as it may take several days to a week or more to see the full effect of the medication. A realistic goal for therapy is not, in fact, elimination of symptoms. The decision must be made on an ongoing basis whether the amount of benefit received justifies the real or potential adverse effects. Accurate quantitative and qualitative descriptions of our targets will allow us to make those assessments. This should be documented on a daily or shift basis, depending upon the setting, and there are a variety of commercially available forms to do this. Whether you use a commercially prepared form or other methods, such as chart notes, it is critical that objective and specific target behaviors are consistently evaluated. This means that the listed target behavior should be clear and unambiguous to anyone who may be monitoring the patient or reviewing the form. Examples of specific target behaviors include hitting, biting, striking out, or refusal to eat. Examples of nonspecific target behaviors that should be avoided would include agitation or restlessness. You can see how the term agitation could mean quite a range of behaviors. Therefore, it would not be considered a valid target behavior for monitoring. The same can be said for monitoring adverse effects. This may be accomplished using the same or similar documentation forms and procedures as those for efficacy monitoring. Again, we must be specific with our description of the adverse drug effect and document whatever action was taken to address the adverse effect. Serious adverse drug reactions should receive immediate attention, which may include holding or discontinuation of the medication or reduction of dose. Here is a list of the most common and most serious adverse effects associated with the use of antipsychotic medications. Many of these effects can be predicted based on knowledge of the activity of these agents at the neuroreceptors. Sedation is associated with agents that are active at the alpha-1A adrenergic or H1 histaminic receptors. Olanzapine and quetiapine are most likely to cause this effect. Alpha-1 receptor blockade is also responsible for orthostatic hypotension. This is an adverse effect that is reported with all of the agents at a fairly similar rate. The risk of falls is about double that of a similar patient who is not receiving antipsychotics. Falls may result in serious outcomes, such as fracture and resultant admission to a higher level of care, which can be very traumatic to a patient with dementia. Typical and atypical antipsychotics have similar risks in this regard. Potent blockade of the dopamine receptor predicts the severity of extrapyramidal or Parkinson's-like symptoms such as tremor, rigid muscles, difficulty swallowing, or changes in gait. Consequently, extrapyramidal symptoms are seen most frequently in patients receiving haloperidol, but atypical antipsychotics can also cause these symptoms, especially at high doses. Effects unique to the atypical antipsychotics are their impact on metabolic measures and weight gain. In 2004, manufacturers of all atypical antipsychotics were advised to include warnings of increased risk of hyperglycemia and diabetes. These drugs may also increase triglycerides. It is unclear if these effects have a significant impact on elderly patients with dementia, but these side effects should be monitored, especially in people with diabetes, hypertension, or hyperlipidemia. People with dementia who receive antipsychotics are also at risk of urinary side effects, such as incontinence and urinary tract infection. The reason for this side effect is not clear. Several of the antipsychotics have the ability to affect cardiac rhythm by prolonging the QTc interval. This effect increases the risk of ventricular fibrillation and torsade de pointe, leading to sudden cardiac death. The number of deaths attributed to this adverse effect is unknown. Elderly patients may be at particular risk for poor outcomes because of pre-existing cardiac disease and their use of multiple medications leading to drug interactions. We have discussed cerebral vascular and mortality risk in the section on appropriate antipsychotic selection. We have used this table previously for the purposes of product selection. It is also useful as we develop a plan to monitor for adverse effects. Once we have selected an antipsychotic, we can use this table to identify common adverse effects of the chosen agent and develop our monitoring plan. For example, since we chose haloperidol for Mrs. Klein's behavior, we would look at the column for haloperidol and be sure to note that we would want to monitor for the possibility of movement side effects. These would include Parkinson's symptoms as well as akathisia, or the feeling of inner restlessness and the urge to move. Although tardive dyskinesia will generally appear later, and we hope that the use of haloperidol will be short-term, we will also need to be alert to the signs of TD. Sedation and orthostatic hypotension are possible, and their combination may increase Mrs. Klein's risk of falls. Other adverse effects are uncommon to absent. Standard care of her medical problems should complete our monitoring. You can see how this same process can be used regardless of the medication chosen. For risperidone, we would need to expand our monitoring to include metabolic effects like weight gain and edema. Olanzapine is very likely to increase weight and triglycerides. While this table helps to identify the most likely adverse effects, we should always be vigilant for other less common adverse events and alert all persons involved in Mrs. Klein's care to report any unusual symptoms or changes noticed after starting the haloperidol. This table provides specific guidance on monitoring adverse effects. It corresponds to the table on the previous slide. Using the two tables in combination will allow you to quickly and easily develop a monitoring plan. So for haloperidol, we would be concerned about movement side effects, sedations, and orthostatic hypotension. Basically, for any potential adverse drug effect, we would closely observe the patient on a continual basis. For Mrs. Klein, we should also complete an abnormal involuntary movement scale, you may know it as the Ames test, at baseline, anytime there is suspicion of movement effects, and every 6 months if she stays on the medication. We need to measure orthostatic blood pressures at least monthly, and we must look out for signs of dizziness or falls. If a different medication is selected, identify its adverse effects and design your monitoring plan in a similar fashion. This approach will improve patient safety, positively impact the care of the patient, and help meet CMS antipsychotic medication use guidelines for patients in continuing care facilities. Mrs. Klein was started on haloperidol 0.25 milligram daily for delusional thinking that had created behaviors that were potentially harmful to her and others. She has been on the drug for approximately 3 weeks. After several days on the medication, her behaviors modestly improved and she began to accept food in the dining area. She still questions the whereabouts of her husband, but there has been an improvement in her belligerent attitude toward another resident, who she had accused of fooling around with her husband. The dose has remained unchanged. Unfortunately, Mrs. Klein has been increasingly demonstrating some of the extrapyramidal symptoms associated with the use of haloperidol. She has started to drool, and her gait has become stiff and unsteady. She does not complain of or exhibit any signs of akathisia. She has otherwise tolerated the drug well, without undue sedation or changes in blood pressure. Given this information, how would you manage Mrs. Klein's medication? When adverse effects are complicating the use of an antipsychotic, these are some of our options. The first consideration should be to look at the effectiveness of the treatment. If the treatment has been largely ineffective at controlling target behaviors, then a case could be made to discontinue the antipsychotic and not restart another. Even if the patient seems to be responding to the medication, a trial off the drug can confirm the efficacy of the treatment and will definitely address the adverse effects. Dosage reduction is another straightforward and simple approach to the problem of adverse effects. Adverse effects are often dose-related and may very well be managed by reducing the dose. Even in patients who are responding to the drug and are not experiencing unwelcome effects, it is useful to reduce the dose to determine if the drug is still necessary, and if so, to manage the patient on the lowest dose possible. Another approach to managing adverse effects is to change drugs. As noted in the adverse effects table, the side effect profiles of the various antipsychotics can be different, and these differences should be considered as we make our decision to change agents. So, what to do? Since Mrs. Klein responded nicely to the low dose of haloperidol in regards to her identified target behaviors, she's eating better and less belligerent, a case can be made to continue an antipsychotic. It would be difficult to reduce the dose of her haloperidol further than the 0.25 milligram we used, so a change to another agent less likely to cause movement side effects would be reasonable. Since all of the remaining choices are reported to be less likely than haloperidol to result in movement disorders, we could choose any. In reality, we would also want to consider other potential ADRs as well as cost. Of the remaining choices, risperidone is the only agent currently available as a generic in the United States, and therefore would be less expensive than any of the other agents, while still offering us the advantage of lower reported incidence of movement disorders compared with haloperidol. Of the atypical antipsychotics, it also has the strongest evidence supporting its efficacy for behaviors and psychosis in dementia. While quetiapine is reported to be least likely to cause movement disorders, it is not without issues as well. Quetiapine is only available as a brand name agent, making it more expensive, and it is also the most likely to cause sedation. Of the atypical antipsychotics that have been studied, it has the least evidence supporting its efficacy. After consultation with the team, a decision was made to discontinue the haloperidol and initiate risperidone 0.25 milligram daily with continued monitoring. So, if the risperidone is effective and Mrs. Klein is not bothered by adverse effects, what then? As mentioned, we should continue to monitor for both effectiveness and side effects and attempt periodic dose reductions, or, in this case, discontinuation due to the low dose used. The limited efficacy and heavy adverse effect burden of antipsychotics in this population often make the choice to discontinue the drug an easy one. Therefore, an attempt should be made as soon as reasonable and should be considered within 1 to 2 months of initiation of therapy. In nursing facilities, CMS guidelines require periodic dose evaluation, and reductions are recommended unless clinically contraindicated. While the standard in this situation is often 6 months, an attempt prior to 6 months would always be reasonable and within the guidelines of good clinical practice. Remember, unless there is clear evidence of the efficacy of a drug, it should be discontinued, as the potential risk of these drugs often outweigh potential benefits. If efficacy is questionable, a decision to discontinue the antipsychotic is perfectly reasonable. Many patients do not experience worsening of symptoms when the medication is withdrawn, and again can be managed with non-drug approaches. It is important to remember to continue monitoring for target behaviors during the period of dose reduction or discontinuation. This monitoring will be helpful in determining if a resumption of the antipsychotic is indicated. I want to thank you for participating in our educational program on the management of problem behaviors and psychosis in dementia. Our team hopes that the information and clinical tools can help you provide the best possible care for people with dementia. Please browse our website for more resources and information and let us know what you thought. Take care.